Part 3. Neurological diseases and their treatment. Chapter 51. Management of neurological disease. How an experienced neurologist uses the history of the patient's illness, the neurological examination, and investigations to diagnose neurological disease is discussed in chapters 1 to 33. This chapter presents some general principles guiding the management of neurological disease. Chapters 52 to 56 cover individual areas of neurological management such as pain management, neuropharmacology, intensive care, neurosurgery, neurological rehabilitation, and managing the transition from childhood to adulthood. Chapter 114 covers palliative and end-of-life care. Details about the management of specific neurological diseases are presented in chapters 57 to 113. Many aspects of management are common to all neurological disorders. These management considerations are the subject of this chapter. Principles of neurological management. Once a neurological diagnosis has been established, it is necessary to develop a management plan. In addition to disease-specific treatments, steps must be taken to provide support for the patient, family, and caregivers. Communicating bad news should be done with compassion, with a goal to offer as much hope as realistically possible, discussed further in Chapter 114. If a genetic diagnosis is made, genetic counseling should be offered to support the patient and also to address the potential for disease occurrence in other family members. A detailed discussion of genetic diagnosis and management is provided in Chapter 48. At present, many neurological diseases are incurable. This does not mean, however, that such diseases are not treatable and that nothing can be done to help the patient. Help that can be provided short of curing the disease ranges from treating the symptoms, to providing support for the patient and family, to end-of-life care. Box 51.1. Unfortunately, a physician who is fixated on the need to cure disease may simply strive to make the diagnosis of an as yet incurable disease and then give no thought to patient management. Such a physician will tell the patient that he or she has an incurable disease, so coming back for further appointments is pointless. The aphorism, "to cure sometimes, to relieve often, to comfort always," originated in the 1800s with Dr. Edward Trudeau, founder of a tuberculosis sanatorium. Any other attitude is not only an abrogation of the physician's responsibility to care for the patient but also leaves the patient without the many modalities of assistance that can be provided even to those with incurable diseases. The neurologist who accepts the responsibility for treating the patient will review with the patient and family all the issues listed in Box 51.1. In fact, it is usually necessary to spend more time with the patient with an incurable disease than with one for whom effective treatment is available. In addition to providing all the practical help available, the compassionate neurologist should share the grief and provide consolation for the patient and family. Both are essential aspects of patient management. Evidence-based medicine in neurology. No treatment should be given to a patient without a good rationale. Although there is growing emphasis on evidence-based medicine, it should be acknowledged that this approach has some limitations. Subjects selected for double-blind placebo-controlled studies must meet criteria strictly defined by inclusion, exclusion, and they may not represent the population for whom the treatment will eventually be prescribed. Such patients, for example, may not necessarily have exactly the same demographic or clinical characteristics as those of the well-defined study population, and they may be taking other medications that could affect the response. For these and other reasons, the findings from controlled trials may often not be generalizable. Furthermore, most double-blind placebo-controlled drug trials are relatively short-term studies, and it is not until a long-term open-label trial has taken place that efficacy and adverse effects are better understood. Moreover, the cumulative experience of a seasoned physician, whose clinical judgment relies not only on the published evidence-based literature but also on personal and often empirical experience, can be of great importance in the management of a specific patient. It would be wrong if this resource were to be disregarded in areas where the relevant literature is not definitive or available. Absence of evidence, usually because the appropriate studies have not yet been done or published, does not mean that support for a specific intervention or application is lacking. Goals of treatment. In defining the goals of treatment, it is important to separate neurological impairment from disability. Neurological impairment, the presence of abnormal neurological signs, allows a diagnosis to be made. Impairment may cause disability. For instance, a stroke may cause a hemiplegia, which is the impairment. The hemiplegia may cause difficulty in walking, which is the disability. The patient may be concerned about the abnormal neurological signs but to a greater degree wants correction of the disability. It may not be possible to correct the underlying stroke lesion or reverse the hemiparesis or other neurological deficits, but symptomatic treatment such as providing physical therapy, a walker, and a wheelchair can mitigate these disabilities. The functional state of a stroke patient who has benefited from neurological rehabilitation may be gratifying as compared with the state of untreated patients. Amyotrophic lateral sclerosis, ALS, is perhaps the disease that epitomizes the role of symptomatic care. Patients with ALS often report being told by their doctor that they have ALS and are likely to die within 3 years. Therefore, because nothing can be done for them, they should go home, put their affairs in order, and prepare to die. A doctor who dispenses such advice is not only uncaring but also leaves the patient without hope and without the symptomatic treatment that could help the patient to circumvent the disabilities attending the disease. The psychological support of a caring neurologist who is familiar with the disease can be of great help to the patient and family. Chio et al., 2004. An increasing number of lay organizations and support groups are available to provide information and services. Patients will often have found these by searching the internet, but the physician should keep available the addresses and contact information of key organizations to give those who need them. Symptomatic treatment depends on the nature of the disease. It can consist of arresting an attack of a disease such as multiple sclerosis, MS, circumventing the effects of the disease, as with antispasticity medications, or end-of-life care for a patient approaching death. This last is sometimes called palliative care, but in fact every treatment short of cure, even in the early stages of a disease, is palliative. There is no cookbook approach to the management of any neurological disorder. Therapy must be individualized, and the selection of the therapeutic strategy must be guided by the specific impairment and tailored to the needs of the individual patient. Arresting an attack. Many neurological diseases cause episodic attacks. These include strokes, migraine, MS, epilepsy, paroxysmal dyskinesias, and periodic paralyses. In some of these diseases, treatment may prevent or halt the attacks. Although it does not cure the underlying disease, aborting the attacks is of great help to the patient. Triptan-class drugs may arrest a migraine, and valproate, a beta blocker, or a calcium channel blocker will reduce the frequency of the attacks. See Chapter 102. Status epilepticus can usually be arrested by intravenous antiepileptic drugs, and the frequency of epileptic attacks can be reduced by the use of chronic oral anticonvulsant drugs. See Chapter 100. Intravenous and intra-arterial thrombolytics may terminate and potentially reverse an otherwise disastrous brain attack, cerebral ischemia. See Chapter 64. Slowing disease progression. Examples of treatments that slow the progress of neurological disease are numerous. A malignant cerebral glioma is almost universally fatal, but high-dose corticosteroids, neurosurgical debulking, radiotherapy, and chemotherapy may slow tumor growth and prolong survival. See Chapters 73 to 75. The beta interferons, glatiramer, natalizumab, or mitoxantrone or other immunomodulatory drugs may reduce relapses and slow the progression of MS. See Chapter 79. Liver transplantation in familial amyloid polyneuropathy may slow or arrest disease progression. See Chapter 106. Riluzole may slow the progression of ALS. See Chapter 97. Despite many efforts to slow the progression of Parkinson disease, PD, no neuroprotective therapy has proved to be effective, although certain monoamine oxidase B inhibitors and dopamine agonists delay the onset of levodopa-related motor complications. Relieving symptoms. Symptomatic treatment is available for many neurological diseases. Relief of pain, although not curative, is the most important duty of the physician and can be accomplished in many ways. See Chapter 52. Baclofen and tizanidine can reduce spasticity, particularly in spinal cord disease, without affecting the disorder itself. Injections of botulinum toxin provide marked relief in patients with dystonia, spasticity, and other disorders manifested by abnormal muscle contractions. High-dose corticosteroid therapy reduces the edema surrounding a brain tumor, temporarily relieving headache and neurological deficits without necessarily affecting tumor growth. In PD, dopaminergic drugs partly or completely relieve symptoms for a time without affecting the progressive degeneration of substantia nigra neurons. See Chapter 95. The physician-patient relationship and the placebo response are both important tools used by the experienced neurologist to help relieve a patient's symptoms. Murray and Stossel, 2013. Circumventing functional disability. In neurological diseases such as Alzheimer's disease, PD, and ALS, the clinical course is usually progressive. Other disorders, such as stroke and spinal cord injury, have an acute onset, and the damage occurs before the neurologist first sees the patient. Although some recovery is expected, substantial functional deficits often persist. In both situations, many ways to circumvent the functional disability and the resultant handicap are available. Neurological rehabilitation is the discipline that concentrates on restoration of function. See Chapter 55. Physical and occupational therapy help the patient to strengthen weak muscles, retrain the nervous system to compensate for lost function, increase mobility, and reduce spasticity. Some authorities believe that cognitive or behavioral therapy may similarly re-educate undamaged cortical areas to compensate for the effects of brain injury and stroke. Orthopedic procedures can be beneficial for rehabilitation. Transfer of the tibialis posterior tendon to the dorsum of the foot can correct a foot drop in appropriate cases. Surgical release of the Achilles tendon and iliotibial contractures in boys with Duchenne muscular dystrophy can delay loss of the ability to walk by 2 years or more. Aids and appliances such as ankle-foot orthoses to prevent foot drop as well as canes, walkers, and wheelchairs can increase mobility and limit handicap. Changes to the home and work environment. A ramp or stair lift, widening of doors to allow wheelchair access, rails for the bath and toilet, replacement of the bath with a shower and shower chair, can be of great help. Only the ingenuity of clinicians and biomechanical engineers, the availability of technology, and the associated cost limit the scope of such appliances. Cochlear implants are commonly in clinical use for persons who were born deaf. Computer-controlled motorized body and lower limb braces may allow paraplegic patients to walk. Hochberg et al., 2006. The range of options available to help a patient with a severe and chronic neurological disease can be illustrated by reference to ALS. In the early stages, the patient may simply need enlarged handles on tools, pens, and utensils to compensate for a weak hand grip or a cane to help with walking. Later, the patient may need a wheelchair and home adaptation. Speech therapy, a communication board, or a computer with specialized software can help when speech is severely impaired. Weight loss and choking from dysphagia may necessitate a percutaneous gastrostomy. An incentive spirometer and an artificial cough machine can protect respiratory function. See the section titled Respiratory Failure, later. If the patient decides not to use a ventilator, end-of-life counseling and hospice will be needed. Management of disabilities in patients with progressive neurological diseases may tax the neurologist's knowledge and ingenuity, but the beneficial effect of symptomatic therapy for patients and families makes the effort worthwhile and demonstrates that no neurological disease is untreatable. Collaboration with colleagues in other fields, e.g., pulmonary medicine, physical therapy, biomedical engineering, hospice care, is essential for optimal care. Principles of symptom management. Treatment of common neurological symptoms. Several symptoms, such as pain, weakness, dysphagia, and respiratory failure, are common to many different neurological diseases. This section outlines the general principles that govern the management of these symptoms. Chapters 52, 53, and 55 provide more complete discussions. Specific treatment for individual diseases is found in the relevant chapters in Volume 2 of this book. Pain. The first step in pain management is to diagnose the source of the pain and assess the prognosis of the disease. See Chapter 52. Consider, for example, a patient with incapacitating pain in one leg from carcinoma infiltrating the lumbosacral plexus on one side. This patient's life expectancy may be measured in weeks or months, and progressive plexus damage will produce leg paralysis. Destructive procedures and narcotics are justified in this situation. Surgical interruption of pain pathways is considered the final choice to relieve pain from carcinomatous infiltration of the lumbosacral plexus. Such procedures include surgical or chemical posterior rhizotomy, contralateral anterolateral spinothalamic tractotomy in the mid-thoracic region, and stereotactic contralateral thalamotomy. Tachyphylaxis for narcotics can occur, and the oral dose of narcotics required to control pain may rise rapidly in patients who live for several months. This does not appear to occur with morphine administered by an intrathecal or epidural spinal catheter using a subcutaneous infusion pump. Narcotics should not be used for patients with non-malignant chronic pain syndromes such as painful polyneuropathies or low back pain because of the development of tachyphylaxis and the risk of producing drug dependency without pain control. Manchakanti et al., 2012. Biofeedback, hypnosis, and acupuncture may help some patients to control their pain. Antidepressant drugs are of benefit in many chronic pain syndromes by blocking the neurochemical transmitter mechanisms of central nervous system pain pathways as well as treating depression. Many patients are resistant to taking antidepressant drugs for pain because they insist that the pain is real and not due to depression. The effectiveness of antidepressant drugs for pain control is a point that must be clarified in such instances. Sometimes a single drug may be effective, but frequently a combination of a selective serotonin reuptake inhibitor, SSRI, and a tricyclic antidepressant, TCA, is better. Sensory loss, paresthesias, and burning pain. Occasionally sensory loss produces an intolerable positive sensation termed anesthesia dolorosa that may respond to a combination of a TCA with either carbamazepine, gabapentin, pregabalin, or an SSRI. Paresthesias generally result from damage to the large diameter myelinated axons in the peripheral nerves or posterior columns of the spinal cord. Patients who complain of burning sensations from small fiber peripheral neuropathies are often helped by a TCA, an SSRI, pregabalin, or a combination of these. Weakness. The management of weakness, considered more fully in Chapter 55, is a major component of neurological rehabilitation. Choice of treatment depends on the extent, severity, and prognosis of the patient's weakness. For example, weakness of flexion of the ankle due to Charcot-Marie tooth disease may be treated with a triple arthrodesis of the foot. Such a procedure, however, would not be appropriate to overcome the foot drop caused by a more rapidly progressive condition such as ALS. For such patients, an ankle-foot orthosis is best. Most neuromuscular conditions benefit from exercise, although fatigue may limit the amount of exercise that can be tolerated. Myasthenia gravis, however, is worsened by exercise. Weakness due to upper motor neuron disease can be addressed by physical and occupational therapy to promote the use of alternative neuronal pathways. Medications such as baclofen, tizanidine, and botulinum toxin injections reduce spasticity and may improve function in upper motor neuron disorders. Ataxia. Ataxia can result from cerebellar dysfunction or sensory deafferentation. A weighted cuff, wrist weight, placed on an ataxic limb may lessen kinetic tremor. The added inertia reduces the amplitude of the involuntary movement during feeding and other activities of daily living that require coordinated movement. Gait ataxia is best managed with the use of mobility aids such as a cane, walker, wheelchair, and other measures designed to prevent fall-related injuries. Displacing the center of gravity forward improves the gait of elderly patients, whose loss of postural reflexes causes retropulsion and falls. Increasing the height of the heels on shoes and lowering the walker so that the patient must stoop forward displaces the center of gravity forward. Slowness of movement or abnormal involuntary movements. Along with rest tremor and rigidity, slowness of movement, bradykinesia, is one of the clinical hallmarks of PD and other Parkinsonian disorders. Bradykinesia usually responds to dopaminergic therapy. Conversely, excessive involuntary movements, such as chorea and stir eotypies, typically decrease with drugs that deplete dopamine or block dopamine receptors. Postural tremors, e.g., essential tremor, often remit with beta blockers, primidone, and topiramate. Botulinum toxin injections are considered the treatment of choice for most focal dystonias and may also be effective for movement disorders including tremors, tics, and conditions associated with abnormal muscle contractions. Stereotactic surgery, particularly high-frequency deep brain stimulation, is now an established therapeutic strategy in patients with severe movement disorders that continue to be troublesome or disabling despite optimal medical therapy. Aphasia and dysarthria. The treatment of language disorders is, in principle, very similar to that of limb weakness. Speech therapy can improve aphasia by retraining contralateral speech and non-speech areas of the brain to compensate for the effects of damaged speech centers. If the lesion is limited, some aspects of language function may be preserved and thus provide an immediate mechanism for communication. For instance, an aphasic patient may be able to communicate through writing. With speech therapy, Dysarthric patients can learn to slow their delivery and emphasize words, thereby improving the clarity of speech. Respiratory failure. Respiratory failure may develop in several neurological diseases. Box 51.2. See also Chapter 53. Patients with chronic neuromuscular diseases often complain of respiratory distress when they are close to respiratory failure. Patients with a weak diaphragm experience dyspnea when lying supine because the abdominal contents prolapse into the chest, thereby lowering the patient's vital capacity and tidal volume. A neurologist or pulmonary specialist who is relatively inexperienced in neurological problems affecting respiration may underestimate the warning signs of potentially fatal respiratory failure. This is particularly true in myasthenia gravis and Guillain-Barré syndrome. Blood gas measurements do not change until late in the development of respiratory failure in chronic neuromuscular diseases. By the time evidence of hypoxia and hypercapnia appears in the blood, the patient may be bordering on acute respiratory collapse. Reduced vital capacity, patient distress, and a good knowledge of the disease are better ways of judging impending respiratory failure. Hutchinson and White, 2008. A patient with Duchenne muscular dystrophy and a vital capacity of 600 milliliters may survive for several years without dyspnea. A patient with myasthenia gravis who has a vital capacity of 1200 ml but is anxious, sweating, and complaining of dyspnea is at serious risk for the development of fatal respiratory paralysis. With borderline respiratory function, sleep or sedation may produce carbon dioxide retention and narcosis, leading to further respiratory suppression and death. Ethical considerations in the treatment of respiratory failure. Respiratory failure was once invariably fatal but is now commonly treated by non-invasive positive pressure ventilation in the early stages and by intubation and positive pressure ventilation in the terminal stages. Radanovic et al., 2013. The treatment of chronic progressive respiratory failure in neuromuscular diseases such as ALS and muscular dystrophy is highly challenging. Moreover, cultural differences in different countries must be recognized. For example, in Japan, it is established practice to provide the ALS patient with a tracheostomy and positive pressure ventilation when signs of early respiratory failure appear. In Western countries, many patients consider life on a ventilator unacceptable, and the neurologist must discuss quality of life issues with the patient and family before proceeding to intubation. Ideally, decisions about life support measures should be made long before the patient is in acute respiratory distress because it is more difficult to make these decisions when death is imminent. Patients and families require considerable counseling by the neurologist and may benefit from speaking with others who have experienced the situation, such as a patient on a ventilator or a person who has lost a relative to ALS. Many patients cannot make a definitive decision about life support measures and so defer the decision until the emergency occurs. In these matters, the decision of a competent patient or the healthcare surrogate, in cases of an incompetent patient or one with whom communication is impossible, holds primacy. For instance, a 40-year-old patient with ALS may request respiratory support to see a child graduate or marry, even though there is no likelihood of recovery. On the other hand, a request to continue ventilator support for a 90-year-old patient with cancer and severe dementia cannot be considered to be in the best interest of the patient, and the physician should convey the hopelessness of the situation and the patient's unnecessary suffering to the next of kin. Patients who decide against ventilator support should provide a living will or terminal care document to their physician and next of kin and legally grant to a designated person, the healthcare surrogate, the power of attorney to make medical management decisions for them if they become incompetent. Even if patients have prepared living wills, they will be taken by emergency services to a hospital emergency department and be intubated unless proper arrangements are in place for end-of-life care at home, usually through hospice services. For patients who decide to request ventilator support, health insurance and economic matters must be considered. Although the availability of insurance to cover the cost of ventilator care is paramount in the United States, in Japan the health insurance system pays for the cost of 24-hour home ventilatory care for all ALS patients. The patient with a tracheostomy may still be able to talk using a valved tracheostomy tube or a partially inflated cuff, but many such patients lose bulbar functions and must use communication devices such as computers or letterboards. Many of the conditions listed in box 51.2 also cause limb paralysis, which further impairs the ability to communicate. Quality of life usually becomes an issue when ventilator dependency becomes permanent. In many patients, the prognosis becomes clear within a relatively short time, as with stroke and coma. Because the patient is unconscious, the healthcare surrogate or, if such a person is not designated, the next of kin must decide, with the advice of the doctor, whether to continue respiratory support. If the healthcare surrogate or family of an unconscious patient requests that respiratory support be discontinued, it is standard medical practice in most parts of the world to end it. The legal and ethical issues are more complex with an awake and competent patient who requests that the ventilator be switched off. Although the legal systems in many parts of the world accept that such requests fall under the right of the patient to refuse medical treatment, involvement of a hospital ethics committee is strongly recommended. Legal issues. There are serious practical and legal aspects patients and families must face when they or their relative is diagnosed with certain types of neurological disorders. Perhaps the most common is the question of whether the patient can drive. Most states have laws that govern particular circumstances. For example, some states require physicians to report to regulatory agencies, e.g., Department of Public Health, Motor Vehicle Department, any patient who has a seizure or alteration in consciousness, motor control, or vision if these symptoms are likely to recur. Failure to do so puts the patient and physician at risk for criminal and civil prosecution. As public debate on such matters evolves, there may soon be similar laws related to cognitive function and judgment. Certain types of employment may also have specific restrictions, e.g., for airline pilots, commercial drivers, construction workers. Neurologists must be completely familiar with these rules and policies in the state where they practice. It is often very difficult for the physician to inform patients that they will be reported because of their diagnosis and/or symptoms. Frequently, the patient will object and ask that this not be done, as it would result in significant practical and economic hardship. Losing the privilege of driving is also associated with a loss of personal freedom and independence. Nevertheless, it is the neurologist's responsibility and duty to explain the reasons for such decisions, the consequences of not doing so, and the associated risks. It is prudent to give examples. Tell the patient what could happen if he or she had a seizure while driving, that the patient or others could be injured or killed, and that if the patient were killed, his or her family would be liable for the financial consequences. When there is a realistic chance of alleviating the patient's disability, indicate that with proper treatment, the restrictions may be dropped and the privilege reinstated. Implications for clinical practice. The numerous and multifaceted aspects of modern management of neurological disease presented in this chapter serve to underscore an expanded role for the neurologist in clinical practice. Improved diagnostic methods identify affected persons more often and earlier, and patients with serious or even fatal disease are living longer, so that the physician-patient relationship may be prolonged. It is essential for today's clinical neurologists to recognize that their scope of practice involves much more than diagnosis. Although a correct diagnosis is essential, the clinician's proper focus is on the treatment and management of the patient and the disease.